Good afternoon, everybody, and welcome to Diabetes and Ramadan webinar from Gulf Association of Diabetes for Endocrine and Diabetes. Today, we have 3 eminent speakers for diabetes and Ramadan, and this will be 3 talks. We will start shortly. So we will start with Dr. Bachar Afandi, who's consultant endocrinologist and head of endocrinology division at Tawam Hospital and clinical professor from United Arab Emirates University. He will talk about fasting risk assessment. Welcome, Dr. Bachar.
Thank you, Dr. Naji. It's my pleasure to be a part of this activity with my dear colleagues and friends, Dr. Yousef and Dr. Mohammed. My presentation will cover the following areas: the potential risks during Ramadan fasting, physicians' disagreement on previous risk classification. I will talk about diabetes and Ramadan risk calculator, and then I will talk about medical and religious recommendations based on the new risk calculator. Then I will review a few scenarios and I will score these scenarios. I would not talk about management, only scoring, and then I will finish my talk. Now, as we all know, Ramadan fasting is actually associated with many risks to patients with diabetes. And that will include hypoglycemia for type 1, type 2, and even gestational diabetes, even on diet. Hyperglycemia for patients with type 1 diabetes, type 2 diabetes, and also we reported in GDM patients, even on diet. Then we get dehydration and thrombosis, and finally, DKA, especially in type 1 diabetes patients. However, now with the use of SGLT2, many have reported increased incidence of DKA in patients with type 2 diabetes related to SGLT2, but also related to COVID-19 infection. Previously, risk stratification for patients with diabetes included the type of diabetes, included the glycemic control, the history of hypoglycemia and DKA admissions, and the other comorbidities. So according to the old classifications, patients with acute renal failure or even chronic renal failure and also congestive heart failure, coronary artery disease, all of these patients were classified as high-risk patients, as was type 1 diabetes patients and also any patients with past medical history of hypoglycemia and any comorbidity. So that's why we had a lot of disagreement among physicians on the classification. Actually, added to that, we have our patients who used to fast with no medical advice at all, and that would be about 40% of our patients. And not only that, we had a 78% of very high-risk patients according to the old classification, 78% who fasted against medical advice, and many of these patients, they fasted safely. So that probably exaggerated the disagreement among physicians. In addition to that, we have many other causes. We know that we have no adequate guidelines. We have no evidence-based medicine on many aspects, and I will talk about that later. Classifications also will depend on the provider of expertise, which is different for many providers. That's why you get different classification. We have many and a lot of missing information about patients because we do not share charts, medical records with other institutions or the private healthcare section and so on. We have poor communications even among the same hospital, the same departments. Then you will get different classifications. You have competing perceptions. According to many studies, physicians do recommend fasting in certain countries more than other countries and so on. Very important, the cultural variances, and it could be different goals and values for many physicians. So the causes for having disagreement among physicians is actually, there are so many causes for that. Now, consequences are clear to all of us that patient would not understand why physicians are classifying him differently or her differently, why this physician is saying do not fast and the other one said you have to fast and so on. Patients would not trust physicians anymore, and that could affect the patient's safety when they're confused whether to fast or not to fast. So that was a real problem. For physicians, it's a huge problem because it's actually, if you think about it, it's not fair to have the decision of fasting for some complex cases, depend on one physician with minimal or limited or even high expertise. So it's a problem for this physician and for his colleagues. And then you would get the liability when physicians give different recommendations, and probably many physicians will be pushed to, read more and study more about the condition. Solutions are also clear. So we have to, all of us, we have to improve documentation. We have to improve communications between providers. We have to increase the knowledge for physicians from different specialties. Remember that this patient is not only your patient, he could be a patient of cardiology and nephrology and so on. Then we have to establish relevant guidelines, and we have to unify our stratification protocols. So this is where the development of diabetes and Ramadan risk calculator came from. But before that, we had many groups were working on that same aspect of Ramadan. And actually, our group reviewed the potential risk factors that are not addressed in the previous risk calculation, including age and gender, duration and weather, type of treatments, many types of treatments, the new agents, motivation, sleep pattern, exercise patterns, many aspects, many factors were not addressed in the past. So that's why probably, probably because there was no enough evidence for these points, but however, these points will increase the disagreement between physicians. Now, the risk calculator was an attempt actually to try to help ourselves and physicians to try patients in a structured approach. So you will get the same evaluation for the same patient, even if this patient, so many providers, even not endocrinologists, even surgeons, they could evaluate the patient in the same way. We had actually studied 14 elements and we considered them and scored them differently. So we gave a score of 0 for optimal situation, if no complication at all, and we gave the highest score for the worst scenario. For example, for the presence of hypoglycemia, we gave a score of 0 for no hypoglycemia at all, and we gave the highest score for hypoglycemic and awareness, which means you cannot fast. And this is, just an example. You can see here the elements. We had, again, 14 elements, but we had about 50 factors that we addressed with different points. And you can see here for type 1 diabetes, we gave 1 point. People might say type 1 diabetes would need more points. Probably true. However, type of diabetes, only 1 point. When you go over the other points, including hypoglycemia, SMBG, CGM, you will get more points, and that will be more relevant to type 1 diabetes. Then we covered duration of diabetes, presence of hypoglycemia, again, 0 for no hypoglycemia, 6.5 for the highest one, hypoglycemic and awareness, level of glycemic control, 2 for an A1C of more than 9, and 0 for an A1C of less than 7.5. SMBG, if patients are not doing SMBG, they will get 2 points. If they're doing SMBG as indicated, as recommended by their physicians, they will get a 0 point. History of acute complications was very important. We gave a score of 3 for DKA or HUNT in the past 3 months, and we gave 1 point for that if it happened in the last 12 months. and 0 if there was no history at all. Chronic complications were also covered. We said if the patient has unstable microvascular disease, then this patient should not fast, and that will give a score of 6.5. If it is stable, a score of 2. And again, this is after reviewing the available literature on this subject. Other chronic complications include GFR of less than 30, 6.5. And this, this area here is being developed even further by our colleagues from nephrology. Pregnancy, if patient is poorly controlled, should not fast, 6.5. If a patient is well controlled, 3.5. No pregnancy, 0. We gave a score for frailty. So if a patient has impaired cognitive function or frail, a score of 6.5 was given. If no frailty or loss of cognitive function, then a score of 0. Then we went to the physical labor for somebody who walks for many hours intensively. Then this patient will get a score for that. We spoke importantly about previous Ramadan experience. We gave 1 point for that. Location and fasting duration is very important. So if the fasting is more than 16 hours, we gave 1 point. Then we spoke about the diabetes treatment, and we gave the highest score for multiple daily premixed insulin. As you know, this is related to recurrent hypoglycemia and poor control of diabetics. And this is an insulin that is being used in many countries over the world. Then we gave sulfonylureas, the new ones 0.5, the old ones, old generation 1 point, and other treatments that did not include sulfonylureas or insulin, we gave 0 points. Now, after you add all points, then you will get a total score, and we classified as a group a total score between 0 and 3 as low risk, 3.5 to 6 as moderate risk, and if the score was more than 6, we gave a high risk score. So based on that scoring, we made our recommendations. We made our medical recommendations that if the score is low risk, then fasting is probably safe. Patients could fast, given the facts that you should evaluate them and modify their treatment, and you should monitor them. The same almost for moderate risk. However, the safety for this level, this class is not certain. So patients, again, should be evaluated, full evaluation, and they should medications adjustment, and you should monitor them. And if the level was high, then fasting probably not safe, and they should not fast. You should advise them not to fast. Now, if you look at the religious recommendations, which I'm not going to go through, but they were based on the same, pattern, and that happened after many, correspondence between us and the religious authorities in Al-Azhar, where we explained to them what is the risk here and here. And of course, they made their decisions based on that and also on many religious principles. Now let's go now to a few cases, and we score them accordingly. Now this is a 67-year-old lady, type 2 diabetes for 17 years, hypertension, hyperlipidemia, coronary artery disease. She had an MI 7 years ago. She has no complaints, no chest pain, no polyuria, no blurred vision, but she is not compliant with her diet. Her fasting blood glucose is elevated between 120 and 180, her postprandial 180 to 240. She has no reported hypoglycemias. She has good physical and mental functions. Her fasting duration is 14 hours. And she has regular fasting actually every Mondays and Thursdays, all Mondays and Thursdays with no issues. And she had no issues last Ramadan fasting. Her medications include sulfonylureas, and that's only the relevant medications. Her blood pressure 138/86. She has diabetic retinopathy, and she has poor pulses. Her most recent ejection fraction was 60. She has normal LFTs and TFTs, and her GFR is 76. Her LDL not at goal 127, and her A1C is 9.2, poorly controlled. So the question would come here, what do you think the estimated risk for this patient? And what would be her calculated risk score? And what are your recommendations? Now we asked the same question in a survey that was sent to 320 physicians, and 28% of the physicians said that this patient is high risk and should not fast. And actually 19% of the physicians, of the respondents, said that this is a low risk patient. Very confusing to patients and family. So her risk calculation, if you think about it point by point, she will get 1 point for a duration of 10 years. She will get 2 points for an A1C of more than 9. She will get a 2 point for stable cardiovascular disease. No other points here. 0, 0, 0, all of them. 0, 0, 0 also for previous experience and physical labor and duration of fasting. And she gets another ½ point for her being on glycoside MR. And now the calculated score actually is 5.5, and this is a moderate risk patient. This is really nice to tell the patient the exact score you and your colleague next door and the other physician and the physician in cardiology and so on. Again, recommendations are fasting safety for this patient is not clear, not certain. You need to evaluate this patient. You need to adjust medications, and you need to monitor her during Ramadan. Religious recommendations are almost similar. Very important that when you evaluate this patient in the pre-Ramadan evaluation, you need to have the family there to attend your, counseling to this patient. You need to discuss the risk, and you need to talk that this risk is not clear. And you have to talk about meal planning, physical activity, and how you want to modify the treatment and the time of the medications. I'm not going through this. I know Dr. Yousef and Dr. Mohammed will talk about that later. You need to talk about the importance of blood glucose monitoring and how to manage hypoglycemia or other acute complications. And very important to talk about breaking the fast rules. Breaking the fast rules are known to you, to the audience here. And I would mention here blood glucose of less than 70 or more than 300. Symptoms and signs of hypoglycemia or hyperglycemia, even if the patients have no hypo or hyperglycemia. And of course, patients should be advised not to fast on acute illness days. Let's move to a type 1 diabetes patient. Another case, 17-year-old, type 1 diabetes for 8 years. He's asymptomatic, no history of hypoglycemic and awareness, normal physical examination, normal retinal exam. He checks his blood glucose only whenever symptomatic. So this is suboptimal. He's on glargine and novorapid insulin. Fasting is 15 hours. He works as a hospital porter. He has hypoglycemia once every few days, and that is symptomatic actually. He has no hypoglycemia last Ramadan. He fasted all Ramadan long with no issues. A1C 7.5. GFR 112, no history of DKA in more than 1 year. So again, what do you think the estimated risk level for this patient? And I will give you the calculated one and what are the recommendations here. This is clearly in the old classification. It used to be high risk for sure because of the type 1 diabetes. Exactly the same for the first case. It was a high risk in the old classification because of the A1C of more than 9. And the cardiovascular disease. So for this patient, again, we sent it to 320 physicians, and 52% said this is a high-risk patient, and 20% said this is a low-risk case. And remember, these providers may be our next-door providers. So clearly, this patient might go in the same institution to 3 different physicians and get 3 different recommendations. Risk calculation for this patient, type 1, 1 point. Hypoglycemia, less than once per week, another point. SMBG not done as indicated, a third point for that. Then no points here for DKA, for chronic complications, for pregnancy, of course, for frailty, 0 points in this page. 0 here, except for the basal bolus insulin, he gets 2.5 points. And if you add them all up, you will get a 5.5. And again, this patient is a moderate risk patient. Again, it is clear to many of us that the most difficult cases are the cases with type 2 actually, and patients who have moderate risk, not clearly safe or high risk. So these are the patients we should focus more on, because again, in the recommendations, you would have to tell them exactly, give them the facts, and you have to give them a full medical evaluation. Past experiences are very important for these patients, medications adjustment, and strict monitoring of blood glucose. You have to have an access for these patients to call you in order to modify their treatment again, especially for high-risk patients if they insist on fasting. You have to discuss the risk with this patient. You have to discuss, again, diet and activity. You have to talk about acute complications, DKA and hypoglycemia and hyperglycemia for this patient with type 1 diabetes. You have to talk about modification of insulin management. Close monitoring, also very important. Diabetes alert, very important to type 1 patients, and it might make a big difference for them. Glucagon should be available for all of them. And again, breaking the fast rules, very important. Just one point I want to remind here, that really SMBG and CGM is really very important for type 1 diabetes patients, because many of them might have what we labeled as unrecognized hypoglycemia or hyperglycemia that was discovered only on CGM. So please make sure that these patients, even if they're well controlled, that they should monitor their blood glucose. The last case here is hyperglycemia in pregnancy case, 26-year-old GDM on basal bolus insulin. She has hypoglycemia less than once per week. She is not well controlled, and she has no other health issues. Her A1C 5.8 and her fasting hours less than 16, GFR is less than 124. What do you think her estimated risk? What's her calculated risk? And what are your recommendations? Again, same case, went to 320 physicians, 86% said this is a high risk, but there is 1%, I don't know why, he said this is a low risk. Very confusing again. Risk calculation for this patient, very simple. Pregnant woman, not well controlled, 6.5, high risk, advised not to fast. Very simple. Even if she were well controlled, her risk is 3.5, and moderate risk, safety unclear, and should be again advised not to fast. And again, this patient is poorly controlled on basal bolus insulin, not achieving targets. Even she has hypoglycemia, and her risk is high, should be advised not to fast. And this is the same for religious recommendations. Management plan, again, should not fast, should be advised not to do so. But whenever these patients insist on fasting, and this happens a lot actually, probably 40% of our patients, 47% of our patients, pregnant women with hyperglycemia in pregnancy insist on fasting, then you have to go through the whole evaluation pre-Ramadan and monitoring and modification of medications and so on. Monitoring also in pregnancy is very important. We reported that relying on SMBG during pregnancy actually is misleading. So if your patient insisted on fasting, then you have to insist yourself on checking the sugar very often. What are the advantages of this risk calculator? Well, I have many points, but I will say a few of them. It's a very simple tool. It aids physician in decision making. Again, it's not fair and it's not good to have the decision based on one physician. It's very difficult sometimes, and you need some support, and this tool will support physicians. It will eliminate disagreement. It will reduce liability for physicians. It will improve patient safety. It will improve patient trust, and it might motivate patients. Simple tool, very simple tool, one page actually. In our Tawam hospital, this is what we use. It's one click, and you will get the score at the end of the page. Very simple, straightforward. It takes 1 to 2 minutes. Even if you don't know the patient very well, it takes you, not more than 3 minutes. Again, it motivates patients. Yes, it does, because when you sit with the patient and explain these points to the patient, you will educate them. You will actually have clear guidance here. Again, you will have a teamwork. No physician should take the responsibility for classifying one patient. This is a support for everyone. It's sharing the decision with other providers and consistent recommendations. Remember that there are many modifiable risk factors in this calculator, and it's very important to address with your patients. When you talk to your patients, if you control them before Ramadan, you will do a lot better. And if the A1C is lower, then you might move the risk level from high to moderate, from moderate to low. Again, frequency of SMBG, very important. Type and duration of fasting, of work during fasting is very important. Diet and exercise, type of medications. Again, you might consider modifying some treatment before Ramadan, from premixed insulin to basal bolus and so on. Remember, please, that the evaluation process, risk classification process is a continuous process before Ramadan, during Ramadan, and also after Ramadan. Remember that you have to modify their treatment back to what it was before Ramadan. My take-home messages: the Diabetes and Ramadan Risk Calculator provides a unified approach to assess patient risk. Physicians must quantify the risk of all patients and discuss risk score. And actually, we have a lot of research that is ongoing now to validate the Ramadan risk calculation, and it looks by many institutions, including our neighbors at the Imperial College, led by Dr. Sulaiman, shows that it's really, it validates the risk calculator, and it's really very encouraging. And here I must thank the whole group who was a part of this under the leadership of Dr. Hassanin. We did this part on risk calculator assessment, but we have many colleagues that are present in this seminar. I would like to thank them all. And the publication was just published now, last week actually, so please review that. Thank you very much, and Ramadan Kareem to all of you.
Thank you, Professor Bachar. Nice presentation and enjoyable. And we will keep the question and answer at the end. We'll move now to the second speaker, Professor Yousef Saleh. He's a professor of medicine and endocrinology, King Saud bin Abdulaziz University for Health Sciences, consultant endocrinology, division of endocrinology, Department of Medicine, King Abdulaziz Medical City. And he will present type 2 diabetes therapy in Ramadan. Welcome, Professor Yousef.
Assalamu alaikum wa rahmatullah. Thank you, Naji. Assalamu alaikum, everybody, and good evening to all of you. Glad to be here again with GAED, and happy to present on this webinar. It's always a great pleasure and honor to meet colleagues in the Gulf region and the rest of the world. Glad to see also more than 700 participants attending this webinar. This is a clear proof for the great success that the Gulf Association of Endocrinology and Diabetes, led by the board of directors, doing for the academic activities in the region. So the holy month of Ramadan is essential to fast, and as Bashar mentioned, majority of patients, even high-risk patients, refuse to obey the recommendation of their physicians to fast the holy month. And for example, type 1 and pregnant diabetics, we've been observing them fasting for years, and yet when we get trained in North America, for example, or Europe, we get informed that it's prohibited for them to fast. And when we came back, we observed them fasting without much of complications, actually. And then studies have shown that, for example, DKA incidence in Ramadan is not increased compared to Sha'ban or Shawwal. Many changes happen during the holy month of Ramadan: the pattern of sleep, the diet type. Many foods appear only in Ramadan. I don't know why that happens, but this happens all over the Muslim world, and in any part of the world where there are Muslim practicing Ramadan, certain foods full of calories appear during the holy month, and mealtime change. So people change their meal time and pattern, and caloric intake is increased so tremendously. We did a small study back in 1997 where we gave 15 patients glucometer, a small one during the holy month of Ramadan, and I had the pleasure to do that when I was preparing for my fellowship. And we observed huge rises in blood sugars after iftar for a meal. Minimum 300. This is the least of the patients. Of course, they were diabetics, type 2 diabetics. 300s, 400s after iftar is the thing that we have seen. And this has been documented with the mean continuous glucose monitoring, the CGM, and look at the big jump in the sugar levels post iftar, and it continues for the whole night. So we continue eating the whole non-fasting time in Ramadan till suhoor time. Lots of visits to friends, to family members, and so on. And all of these visits are just full of calories, as you know. The challenges is to check the eligibility and suitability, risk associated, study the risk, and adjust diet, exercise, and drugs, and to counsel on how to monitor blood sugar. We thank God that this document is now updated from 2016. Now we have the 2021, and it's published recently in March this month in Diabetes Research and Clinical Practice, the official journal of the International Diabetes Federation. Risk stratification is a beautiful element where now we have a subjective or an objective assessment of our patient risk. And it's really good to educate our colleagues and to practice this ourselves, where we assess the patient from all aspects. So the beautiful thing of the risk stratification, IDF-DAR risk stratification, is that it makes you not forgetting the many elements that we need to look at, and we sometimes might miss with a busy clinic to look at in our patients. So it continues to remind us of the most important points that we need to look at, beautifully done by IDF-DAR, and 3 categories: the low risk, 0 to 3 points; moderate risk, 3.5 to 6 points; and high risk, more than 6 points, where you advise these patients against fasting. Always the clinical judgment of a clinician is very important in telling some of these patients, please do not fast. It's risky to you, it can cause harm to you, and our religion advise against self-harm. So we have to look and assess the risk of hypoglycemia, hyperglycemia, and try to prevent the most important thing during fasting, which is hypoglycemia. Diabetic ketoacidosis is still a threat to type 1 patients, and type 2 are at risk of dehydration with prolonged hours of fasting, especially in hot areas in the world. And the risk of thrombosis with hyperosmolar state is known to everybody. 5-fold increment in the risk of hyperglycemia and 7.5-fold increase in severe hypoglycemia. This is, for example, an EBDR trial or study. So the risks are really there, and very important to look at and try to minimize them as much as we can. We always advocate pre-Ramadan assessment, where we risk stratify and make the exemptions and removing misconception. And believe it or not, till now there are some patients who think that measuring blood glucose with a finger stick is prohibited during the holy month of Ramadan. So we have to give them the advices on that's safe and essential, and to tell them the timing of doing these blood glucose monitoring, when to break their fast, and the symptoms of hypo and hyperglycemia, to be aware about them, test their sugar anytime they feel them, and break their fast immediately once they're felt. The Ramadan focused education is very important. That has been seen in many studies that these education targets to healthcare professionals, to patients with diabetes, and to the general public results in tremendous difference in the safety of fasting, with greater glycemic control, better self-monitoring glucose, sustained motivation, and adherence to guideline. And these are the points that we do in our education. And compared to people who did not get educated, hypoglycemia rates in studies has decreased significantly in patients who are educated versus patients without education. In blue, those pre-Ramadan health education, and red, post-Ramadan health education. So those who are not educated had 4 times rates of hypoglycemia. So health education is very essential to the overall diabetes care, and its importance emerged significantly during the holy month of Ramadan. These are the times that we advocate measuring the sugars 6 times a day, 7 times, and at any time where are any feelings of hypoglycemia or hypoglycemia, to test the sugar immediately, break the fast. If the blood sugar is approaching 70, not even below 70, near to 70, they need to break their fast, or if it rises or jumps above 300. All individuals should break their fast, as I mentioned, less than 70 and more than 300. And to me, this is what I practice in my clinic, and I do in each of my clinics when I see these patients these days before Ramadan, which is the ideal thing, but unfortunately it can't happen because of a huge number of patients that all of them need to be seen by Ramadan, before Ramadan, and they are educated, advised, and medications are adjusted. That does not happen. So we need to start this process 2 to 3 months before, to cover the largest number of patients before the holy month. So it's very, very important to do that. Adjustment of diet and exercise. So exercise in Ramadan and diet are very important. And as I mentioned in the beginning, that high calories, high juices with lots of sugar are practiced, and referring to a dietitian to tell them this is what you need to take, this is not suitable for you. Oily foods and sweets and sugars are really important to avoid during the holy month. So I cannot cover this in this clinic, but in this presentation, but a special education for health, for healthy diet is very essential to avoid complications during fasting. Rigorous exercise should be avoided, particularly during the last hours of fasting. We see many people jogging in the last hour of fasting. Is not advisable at all to do that. And I think even for healthy people, is not the time that you strain your muscle and get anaerobic oxidation in the muscle cells, and you think that is suitable. You're already hours of not taking any fluids, and the dangers of dehydration always there. And this applies more and more importantly to patients with diabetes. So they need to advise to maintain their normal physical activity during Ramadan, and that physical exertion involved in Tarawih prayer should be calculated within the physical exercise advices, and to take their exercise, whatever they do, during the non-fasting hours. Now, drugs adjustment is very important, and all of them should receive this advice. Adjustment, I'll take these medications one by now right now. Metformin, very easy to adjust. If it's once daily dosing, then the dose is taken at iftar time. Twice daily, no dose modification usually is required. Take at iftar and sahur. The risk of hypoglycemia with metformin, as you know, is very low, and the full dose can be taken, especially for those who A1C is above 7%. For those who are having much lower A1Cs of 6% or lower, then you might need to practice some cautious for sahur dose and lower it. 3 times dosing, morning dose to be taken before sahur, and you combine the afternoon dose with those taken at iftar. So for example, 500 TID, then you take 1 gram at iftar and 500 at sahur time. Slow release metformin, no dose modification usually required. You just take that dose at iftar time. Now, other agents, acarbose, there is no need to adjust the dose, and this applies also to bioglitazone. These medications are taken the same way. Risk of hypoglycemia is not there, and you just need to just swap the timings, and that's all. What about short-acting insulin secretagogues, mainly talking about sulfonylurea? The short-acting 1-meglitinides need to be taken if it's based on a 3-meal dosing, are distributed between futur and or iftar and suhoor time. These are the short-acting secretagogues. GLP-1 receptor agonist, the dose titrated prior to Ramadan, at least 2 to 4 weeks is required. We personally do not call to increase the dose of GLP-1 receptor agonist, for example, the once daily dose of semaglutide, for example, not once weekly dose semaglutide, to be started or to be titrated during Ramadan, mainly to avoid any sort of complications. We know that the 0.25 milligram of weekly semaglutide is mostly does not cause much of symptoms. It's just a preparation of the body to the 0.5 and the 1 milligram doses. But even that dose, we've seen it causing some problems to some of the patients. So preferably that you either start earlier and titrate and reach the 1 milligram before Ramadan, or delay this or the start of the medication till after Ramadan. If your patient insists, then use the 0.25 dose of semaglutide once a week during Ramadan. Do not upgrade or up titrate to 0.5 during the holy month to avoid nausea while the patient is fasting. There is a consensus statement that is going to be issued regarding the oral semaglutide, where again this medication needs specific requirement to be taken on empty stomach, and then a certain amount of water, and then to avoid eating for a couple of hours afterward, which makes it really having some practical issues during the holy month of Ramadan. So again, the start and titration of this medication preferably to be done before Ramadan or after Ramadan. Do not DPP-4 inhibitors do not require treatment modification during the holy month of Ramadan. What about sulfonylureas? Once daily dose take at iftar. Individuals with well-controlled blood glucose level, maybe also you need to reduce that dose of their sugars. Diabetes control is really strict to avoid hypoglycemia, although this is very unlikely because, as I mentioned, Ramadan food is quite full of sugars and oily. So once daily dose, you switch the dose to iftar time. So those who are taking twice daily dosing, iftar dose remains the same, full dose, and those who are well controlled, you need to cut the dose at suhoor time, maybe 50% or 30%, whatever you think is proper according to the patient blood sugar and A1C. All the drugs like glibenclamide carry a higher risk of hypoglycemia and should be avoided. There are a lot of issues regarding the old generation sulfonylureas, while the new generations like gliclazide MR and gliclazide and glimepiride, lots of studies, and I'll lighten or heighten this on in the subsequent slides. So glibenclamide has many issues, especially also the cardiac issues, cardiac safety, and then the severe hypoglycemia that might happen. So we do not advocate using them during Ramadan or even before during the regular hours. What about Sdlt2 inhibitors? They are recommended to be administered at the time of evening meal, iftar time, and to increase fluid intake during the non-fasting hours of the holy month. They do not require a treatment modification during Ramadan, but if somebody has multiple medication, then review the doses of the other medication to be made to avoid the risk of hypoglycemia. So the risk of hypoglycemia is minimal, but if they are, for example, on high dose sulfonylureas and the A1C is well controlled, then you might think of reducing the dose of sulfonylureas, not the Sdlt2 inhibitor. It might cause some dizziness and dehydration, so people ask to drink fluids and compensate for any diuresis that happens during the daytime. Insulin adjustment, a bit more complicated, but mainly if the patient was on long-acting, intermediate-acting basal insulin once daily, then you shift that dose to iftar time. That's simple. What about short-acting insulin? the normal dose at iftar, full dose, and sometimes I increase that dose because of what we observe at iftar time, the huge share in blood sugar, and especially for those who are on insulin to control their sugar, or they are type 1, you might adjust the iftar dose to a higher dose actually. If they are taking a meal between iftar and suhoor, then they might take a small dose to cover that meal, especially if it's a little bit high in caloric content. And suhoor dose is reduced anything between 25 to 50% to avoid hypoglycemia. And again, to remind that finger sticks are needed, or the use of Libri or CGM to monitor the sugar during the fasting, break the fast, less than 70, above, for me, for type 1, 250, and for type 2, 300. This is a personal sort of advice, but the IDF recommendation is to break the fast if at any time during fasting hours the sugar is above 300 or below 70. And if that happened, the next day you adjust the dose either down by 2 to 4 units or up by 2 to 4 units according to the situation of the individual patient. Higher sugars during fast, next day you need to increase the dose slowly, 2 to 4 units. It's your judgment here. And if it's hypoglycemia, break the fast, next day decrease the suhoor dose by 2 to 4 units. Pre-mixed insulins, once daily dosing, simple, you take it at iftar, and twice daily dose, full dose in iftar, lower the dose in suhoor between 20 to 50%, and 3 doses of these relatively having short and long-acting insulin or intermediate-acting insulin. Then the third dose, if they are on 3 doses, you omit the middle dose, so you take full dose in iftar, reduce the dose at suhoor, and omit the third dose if they are on 3 pre-mixed doses, which is unusual. Insulin pump dosing during Ramadan, basal rate, reduce the dose by 20 to 40% in the last, especially in the last 3 to 4 hours of fasting, and increase the dose by 0 to 20% early after iftar to cover this huge meals that, or intake, caloric intake that happens during iftar time. Bolus rate, normal carbohydrate counting, and insulin sensitivity principles apply to them as if before fasting Ramadan. Just to highlight a point about sulfonylureas, which are mostly prescribed in all over the world, and to alert you to this publication in Diabetes Therapy just last year, and it talks about a consensus report that has been endorsed by many societies in the Gulf region, where we advocate that sulfonylureas, especially the new generation glycoside MR and glimepiride, in several studies has shown low risk of hypoglycemia. The Day Ramadan by our dear friend and colleague Mohammed Hassanein, 0 severe hypoglycemia. Sifri and Aravind, these are 3 studies which have been published and highlighted the safety of these drugs in Ramadan. So the take-home messages that uncomplicated type 2 diabetes can fast in Ramadan, and pre-Ramadan education is important and essential. Islam allows blood glucose monitoring while fasting. Diamicron is suitable oral hypoglycemic agents during the holy month. Holistic approach is advised to treat our patients and to tackle all the aspects of the management. Health education is very important, and education on diet, exercise, and medication overall need to be done before Ramadan. If not, even during Ramadan, in their first week or so, when they come to you, you still need to educate them and teach our patients in the months before Ramadan that you need to visit your healthcare practitioners before the month to adjust your medication, to take the advice about the suitability of fasting, and to do any necessary education and adjustment. Thank you very much.
Okay, thanks, Dr. Yousef. Very interesting talk, and we'll keep the question and answer at the end. Now we'll move to the next speaker, Dr. Mohammed Sofiani. Dr. Mohammed Sofiani is Assistant Professor of Endocrinology, Diabetes and Metabolism, Director of Endocrinology and Diabetes Metabolism Fellowship Program in Saud University, College of Medicine, Adjunct Assistant Professor, Division of Endocrinology, Diabetes, Johns Hopkins University. He will speak about case-based discussion. Welcome, Dr. Mohammed.
So thank you very much, Prof. Naji for the kind introduction, and thanks to the Gulf Association of Endocrinology and Diabetes for the kind invitation. It's really an honor to be with you all, and in particular my colleagues who started this webinar. And I really have to acknowledge the organizer of this webinar, because he or she has done a great job in putting these topics together. I like the flow of the topics, and I think it made my job tonight much easier. So what I'm going to do basically is applying all the concepts that you just heard about from Dr. Afandi and Prof. Yousef Saleh on practical cases that we see in the clinic, or to be specific, the ones that I just saw over the past 2 weeks. So I'm going to highlight the aspects related to risk stratification using the risk score that was nicely presented by Dr. Bachar Afandi. And then we're going to talk about applying practical tips on how to utilize the recommendations that were nicely presented by Prof. Yousef Saleh related to changing medications and their doses. And then I'm going to conclude by a few slides related to the role of diabetes technology in preparing patients with diabetes to fast Ramadan. These are my disclosures, so I could say that I'm not biased to one company versus the other. So this graph or table was shown by Dr. Afandi earlier, so I'm going to skip it. The summary of what has been mentioned so far about the risk calculator is that you end up stratifying your patients into one of three risk groups: either a low risk, where the score is between 0 to 3, or moderate risk, where the score is between 3.5 to 6, or high score for any patient with a score that's greater than 6. We only advise patients or allow patients to fast if they have a score that's 3 or less. We advise against fasting in those who have a score of 3.5 to 6. We strongly discourage patients who have a risk score of greater than 6 to fast. The reality, in particular in Saudi and some of the neighboring countries, that the majority of our patients still insist on fasting, even if they belong to the high-risk group. And this is going to be shown in most of the cases that I will be presenting to you. So without any delay, so let's start with the first case. So this is one of my patients who is a 60-year-old male with history of type 2 diabetes for the past 11 years. He's on oral glucose lowering agents, and he uses CGM to monitor his glucose. He's been seeing me for the past year or so, and he has had albuminuria that has been getting worse. I just saw him 2 or 3 weeks ago, and his albuminuria has gone above 300 milligrams per day. He has no other complications of diabetes. He's currently on metformin, 1500 milligram daily, gliclazide, 60 milligram daily, linagliptin, 5 milligram daily. His A1C is 8%. It has risen from 7.5% the visit prior to this one, and he still reported no hypoglycemia. His BMI is relatively or completely normal at 21. So if you log his comorbidities and factors into this risk calculator, it would give you moderate to high risk, with depending on if you would consider albuminuria as a stable microvascular disease, which I would, that would make him a high risk. If you'd consider this as not a stable microvascular disease, then that would be 4. Nonetheless, he should be advised not to fast. But just like most of my patients, patient is insisted on fasting. So he had already been using CGM, and as you could see that his time in range is about 64%. It is very reassuring that he has no reported hypoglycemia nor discovered on CGM, especially the fact that he's on sulfonylurea. So this also says good things about the newer generation of sulfonylureas. This second page of his AGP report, I show it here basically to highlight this spike that you see after breakfast every day. So his glucose would jump above 200 consistently after breakfast. So you could just imagine what would happen to his glucose in Ramadan after iftar, which tends to be much heavier meal than the regular breakfast, in particular when it comes to the carbohydrates. So because of all of this, our assessment and plan in the clinic was that this is a gentleman with moderate risk for fasting during Ramadan, but he's insisting to fast. So we gave him the recommendations for the next 3 weeks of Sha'ban and then the recommendations for Ramadan. So for the coming 3 weeks, considering the post-breakfast spike, we decided to keep the sulfonylurea at the same dose, 60 milligram. We added empagliflozin, 10 milligram, for 2 reasons. The first reason is the post-breakfast spike, which empagliflozin or SGLT2 inhibitor is hopefully going to help with. And more importantly, because of the rising albuminuria. So hopefully SGLT2 inhibitor is going to slow down that progression of kidney disease, and sometimes it may improve it. Notice that we saw this patient 6 weeks prior to Ramadan. So I felt confident, comfortable, and to start SGLT2 inhibitor in this guy safely. If it was today, 2 weeks prior to Ramadan, I would probably have not started him on empagliflozin because of the worries related to dehydration, risk of DKA, as mentioned by my colleagues in the previous lectures. So we decided to keep the metformin at the same dose as well as the linagliptin. And we also gave him the recommendations on what to do in Ramadan. So metformin is going to be splitted, as mentioned by Prof. Saleh, into 1,000 milligram with iftar and 500 milligram with sahur. Linagliptin is going to stay with iftar, 5 milligram. Empagliflozin is going to stay at the same dose, 10 milligram with iftar. Also notice that I'm not planning to titrate up his empagliflozin dose during Ramadan, but we'll keep it till after Ramadan, and that would be the time when I increase it to 25 milligram, which is usually the most common dose prescribed for patients with diabetes. In Ramadan, we advised him to reduce the sulfonylurea dose from 60 to 30 milligram, because if you remember, his glucose used to be fine within target most of the day, including the fasting hours. It was only or mostly the spike that happens after breakfast. So he's going to take it with iftar only and the other metformin dose with sahur. We counseled him about the importance of hydration during the non-fasting hours and also the DKA symptoms, just so he be alert to these potential complications of SGLT2 inhibitors. So moving to the next case, which is a 63-year-old female with type 2 diabetes for the past 25 years. She is on oral glucose lowering medications as well as insulin, and she does self-monitoring of blood glucose. Unfortunately, she just recovered from ischemic stroke 6 months ago, followed by peripheral artery disease with amputation of 3 of her toes 4 months ago. She also has had CKD stage 3 for the past year or so. She comes to me on metformin, 1,500 milligram daily, glyphosate 60 milligram daily, glargine 12 units per day, and aspart 8 units fixed with each meal. Her A1C, unfortunately, is 14% with all of these complications, and she reports no hypoglycemia nor hypoglycemia and awareness. She has obesity with BMI of 34. So without using the risk calculator, you could tell that she is a very high-risk patient, considering all these factors. Yet, unfortunately, she was still insisting on fasting. So it was a very difficult case for us because of her extremely high risk for fasting, especially in the setting of the relatively recent complications of diabetes that she has had. So for that reason, I counseled her strongly not to fast, but she remained interested in fasting. So I gave her 2 weeks period just to reconsider her decision and come back to me. So this discussion was about 6 weeks ago. So I gave her another appointment, which she actually just had this morning with us, to reopen this discussion and reassess her, hoping that just giving her the 2-week period would give her an idea about how serious this decision is, and also give her some time to reconsider it and discuss it with family members. So in the meantime, 6 weeks ago, I instructed her to reduce the metformin dose because of the CKD stage 3. I increased her aspart dose from 8 to 10. I kept the glargine dose at 12 just because I had no glucose readings on her at the time. And I advised her to use one of the applications that we have been utilizing in our clinic, which is My Dose Coach. I'm gonna explain this more in the next slide. It's basically an application that helps patients titrate their basal insulin doses based on fasting glucose. So it's an automated basal insulin titration that's done between visits. So we explained the app to her, we uploaded it on her phone, and we asked her to do self-monitoring blood glucose and bring those readings. So you could see here just a screenshot from her application. You could see that her dose of basal insulin was increased by the app from 10 to 12 to 15, and eventually to 17 units. This was accompanied by a progressive improvement in her fasting glucose, which is now 111. So I saw her today and she was still insisting on fasting. But at least she has some significant improvement in fasting glucose with the automated titration of basal insulin. So since she insisted on fasting, we had to do our part and help her adjust the medication doses. We provided her with a focused, personalized diabetes education starting from today over the next 2 weeks. We kept the same glargine dose at 17 as was suggested by the application. We increased her aspart dose further to 12 units with meals. We kept the gliclazide at 60 milligram and metformin at 700 milligram for now. We also gave her the recommendations for Ramadan to reduce the glargine dose from 17 to 15 because her fasting glucose is perfect now and her main issue is postprandial hyperglycemia. We asked her to keep the same aspart dose at iftar, which is the new dose that we just increased today. And we advised her to reduce the sahur dose from 12 to 10 because of the risk of hypoglycemia, particularly at her age with the history of ischemic stroke and peripheral arterial disease. We also reduced the gliclazide dose out of caution from 60 to 30 milligrams with iftar only. We kept metformin at the same dose and advised her to ensure hydration in the non-fasting hours, mainly for the kidney disease. And I told her that after Ramadan, we're gonna consider a weekly injection of GLP-1 agonist, hoping that it would help with her high BMI and eventually to substitute the sulfonylurea given her age and comorbidities. So that was the second case. So the third case is switching gears to type 1 diabetes. So it's a 35-year-old male with type 1 for the past 20 years. He is on multiple daily injections and continuous glucose monitor. Fortunately, he has no vascular complications. He is using glargine U300, which is 2JO, 15 units per day. He counts carbs and uses an insulin to carb ratio of 12 and an insulin sensitivity factor of 55. He has a perfect A1C of 6% with no reported hypoglycemia or hypoglycemia in awareness, and his BMI is at 22. So if you use the risk calculator, it would put him at high risk, considering that he has type 1 diabetes, which would give him 1 point, duration greater than 10 years, basal bolus, and he works as IT personnel, so he has lots of walking across buildings, which he expects to continue during Ramadan. So he insisted on fasting, and I wasn't very worried, to be honest with you, about him, despite this high risk calculator, for several reasons. One of them is his CGM report, which, although it shows that his glycemic management indicator is 6.2, which is perfect, yet he has essentially no hypoglycemia. So this is a very meticulous patient who is well educated when it comes to diabetes management, carb counting, etc. So just because his hypoglycemia was 0% and he still has intact hypoglycemia awareness, I said I wasn't very worried about this guy. This is his daily pattern, and it just goes to show you how his basal insulin is perfect during these days. As you see, his glucose is just steady across the day when he's not eating and busy at work. Sometimes if he underestimates his carbs, his glucose would spike after the meal. So we gave him recommendations for both pre-Ramadan, Sha'ban, and Ramadan, as we always do. So I asked him to keep the same insulin to carb ratio, same insulin sensitivity factor, continue the same glargine U300 dose for now until the 27th of Sha'ban. So notice that I'm planning to reduce his glargine U300 dose from 15 to 13 units 3 days before Ramadan. And this is just for the simple reason that this is an ultra long acting basal insulin, which usually requires 2 to 3 days of dose change to see the effect on glucose readings. I also, just out of caution, advise him to increase his insulin sensitivity factor from 55 to 65 during the days of Ramadan, just to minimize the risk of hypoglycemia. I also advised him to probably increase the insulin to carb ratio with sahur, i.e. lower his nutritional dose with sahur, especially if he plans to have a busy day ahead at work. So the case number 4 is a 20-year-old male with type 1 diabetes for 10 years on MDI and CGM. He has no microvascular complications. He uses Aspart 14 units with meals, fixed dose. He doesn't count carbs. He uses glargine 100, the regular glargine, 30 units per day. Unfortunately, his A1C is remarkably above target, and he has no hypoglycemia. According to the risk calculator that you're very familiar with by now, he is high risk, yet he insisted on fasting. His AGP report is very consistent with what we expected based on his A1C. So he has 90% of his glucose readings above target. And you just can see it here. It's above target essentially most of the day and night. What you could see here on his daily reports is one thing that stands out, which is, in fact, when he is fasting for a few hours during bedtime, sometimes if he is sleeping early throughout the night or sleeping during the day on his days off, you notice that his glucose looks much better than the rest of the day. And you also notice that his glucose is steady, stable. So this gives me a hint that this guy's issue is not with the basal insulin. It is mostly with the nutritional insulin or aspart. And for that reason, I told him that for the next few days before Ramadan, he should increase his nutritional insulin with meals from 14 units to 16 units and just keep the glargine dose the same at 30 units. And then in Ramadan, he's going to keep the same nutritional dose with iftar, 16 units that we just increased today. And he may need to increase it to 18 depending on the first few days of Ramadan, just because iftar in Ramadan tends to have higher amount of carbs. I also advised him to reduce the basal insulin dose by 2 units the night before Ramadan. This is glargine U100, so you don't need to make that change ahead of time. So I'm going to conclude my talk with just brief notes on the utility of diabetes technology when it comes to preparing patients for fasting during the month of Ramadan. So it's amazing how we have changed the way we approach Ramadan and preparing patients to fast Ramadan over the past 2 years with the COVID-19 outbreak. So just to remind everyone that all of these things listed on this slide can essentially be done remotely without having your patients come to the clinic. You could provide these patients with blood glucose monitors or better continuous glucose monitors and have them monitor their glucose at home. You could also link these patients' accounts to your accounts in the clinic and monitor their glucose data remotely. That will basically get transmitted to you automatically. You could then set up appointments through telemedicine with these patients. You could also provide online educations to your patients, whether you want to do it through Zoom meetings, just like the one we're having tonight, or simply WhatsApp groups that could be helpful sometimes. You could also provide your patients with personalized diabetes education sessions through Zoom or online meetings between you as the physician and the patient, or sometimes the dietitian and the patient, or diabetes educator and the patient. And this year, we also added the component of applications to automatically titrate basal insulin doses, as I showed you in that patient. So utilizing diabetes technology would help your patients monitor their glucose at home. It would help you as a healthcare professionals to be in touch with your patient, monitor their glucose data remotely. Whether this comes through your Freestyle Libre CGMs, which are widely available across the region, or the Medtronic continuous glucose monitors, or the Dexcom continuous glucose monitors. All of these continuous glucose monitors provide us with the option to remotely transmit data and monitor patients. So this is a quick example of how diabetes technology could be of tremendous value during Ramadan. So this is a 19-year-old female with type 1 diabetes for 11 years, using the old version of Medtronic insulin pumps, the 640G with the Guardian sensor. Her A1C is 8% with the rare hypoglycemia. She is high risk. We uploaded her pump report. We noticed that her glucose is above target most of the time, except when she's fasting during the early hours of the morning, when it tends to drop with just fasting for 6 or 8 hours during sleep time. So you could just imagine during the day of Ramadan that when the fasting is much longer, that this drop in glucose is going to continue and she may go into severe hypoglycemia. So the beauty of insulin pumps, including this one that I now call a relatively old pump, considering that we have the advanced hyper closed loop systems now, but even the 640 can provide patients with lots of advantages. Not the least of them is the feature of suspend before low. So when the glucose is predicted to go low, the pump will automatically suspend insulin delivery. So we activated this feature for the patient. We also increased her basal insulin overnight from iftar to 12 midnight. We also decreased the basal rate by 30% in the last 4 hours of the day, so from 2 p.m. to 6 p.m. We also decreased the ICR with breakfast, so she could get a higher dose with iftar. Sorry, this should be iftar, fatur Ramadan. And we increased the insulin to carb ratio with sahur to lower her sahur dose. So I mentioned to you the automated titration of basal insulin for patients who use injections. One of the applications that we utilize for this is My Dose Coach, which is a recent advancement in diabetes technology. So basically what this does, the patient would check her or his glucose, fasting glucose every day, and log that reading into the app. And then at night, the app will send a message to the patient, reminding the patient to take the basal insulin dose and advise the patient on the appropriate dose of basal insulin for that day based on the fasting glucose. So for example, you could see here that this is a patient who has had 3 high fasting glucose in a row. And then the app automatically recommended that this patient increase the dose of basal insulin from 15 units to 17 units. And then just from this second dose of 17 units, the glucose came down to target. So remember, this is done by the app with the patient without visiting the healthcare professional. So by the time the patient gets to see you in the clinic, you could at least be assured that the fasting glucose is going to be within target. So over the past 2 years, we've been doing lots and lots of virtual clinics, and that's how we prepared some of our patients to fast Ramadan. We also have developed online groups, mostly through our patient support group, the Diatech or Diabetes Technology Support Group, where we conduct online sessions for patients with type 1 diabetes on how to fast Ramadan. And for all of you here, I encourage your patients to subscribe for our group and YouTube channel. And we have actually a session on Ramadan tomorrow. If they are interested in registering, they could just look up Diatech on Twitter. We've had very high and satisfying satisfaction of patients with these online sessions about Ramadan and diabetes. And in fact, the majority of our patients agree that they would recommend that we continue these online sessions to prepare them for fasting Ramadan even after the COVID outbreak is over. So I will conclude with this patient who is one of those who were managed remotely with for hyperglycemia before Ramadan, and he insisted on fasting. You could see that this was during the peak of the COVID-19 outbreak 2 years ago with a time above range of 64%. And then just within 2 weeks during Ramadan of 2020, he was actually insisting on fasting. His glucose improved slightly. And more importantly, he was successful in fasting 27 days of Ramadan, despite all of these discouraging points. So this was not an exception to this patient. In fact, we just presented our data in the Diabetes Technology Society meeting in California a few months ago, where we showed that the telemedicine clinic last year, the pre-Ramadan telemedicine clinic was very effective, and in fact, as effective as the pre-Ramadan in-person visits in preparing our patients to fast Ramadan, as evident by the fact that most of the patients who were able to fast most days of Ramadan, i.e. break their fast only less than 5 days of the month, were actually those patients who saw us virtually before Ramadan or in person before Ramadan. If you compare that to those who had no pre-Ramadan visit in the same clinic with the same healthcare professionals, the majority of them had to break their fast more than 6 days of Ramadan. Not only that, but also the time and range was significantly higher during Ramadan in those who had a pre-Ramadan visit, whether it's virtual or in person. Even when we adjusted for all these factors, age, gender, use of CGM, pre-Ramadan A1C, those who had virtual visits were 3 times as likely to fast most days of Ramadan compared to those who had no visit. Thank you very much for tuning in, and I'm happy to take any questions with my colleagues. Thank you.
Thanks, Dr. Mohammed. Nice presentation. And now I would like to ask all the speakers to be prepared for question. First question for Dr. Bachar. There is a question regarding risk assessment for fasting, but not in Ramadan. Like, for example, after Ramadan or before or Monday, Thursday. Do risk assessment questionnaire or scoring apply or no?
Well, I would say yes, for sure it applies. And actually, many patients, we advise them, we try fast on them few days before Ramadan to see how we adjust their medications. Yes, I would say we should apply the score for these patients, just to know where to move and how to do it and what to recommend.
Okay, thank you. Dr. Yousef, a patient, how to change the dose of a patient with type 2 diabetes, he's in metformin, sitagliptin, and mixed insulin in preparation for fasting Ramadan?
So if metformin is once daily, is taking out iftar. So generally speaking, I missed to talk about those on multiple medications. We know that many patients, they are on multiple oral hypoglycemic plus, for example, long-acting insulin. So you need to spread the doses and to lower the doses, whatever you give, especially the insulin at suhoor, to lower that dose. If you're giving dimecronium R, for example, or gliclazide R in iftar time and sometime who's well controlled, then even that need to be reduced. Majority of our patients do not need major adjustment in their doses during iftar. So iftar is an issue because, as I mentioned, and has been shown in CGM studies, the marked increase in the blood sugar after iftar time. So, and as I said, majority of the patients, they will need more insulin actually. If they come to you back during the second week or so, they will tell you that the 2 hours post readings after Tarawih prayer, although they did this exercise during Tarawih, but still their sugar is in the 300s range. And many of them, they need to be educated to increase their doses at iftar. Suhoor is the concern because you're worried about hypoglycemia with the long fasting hours. So if somebody is on metformin and sitagliptin, these 2 medications are relatively have low risk, DPP-4 inhibitor and metformin, to develop hypoglycemia. So the main concern is, and can be given as at iftar time or even at suhoor if their sugar is A1C is above 7%, same doses. You do not need to cut the doses. If they are on dimicron or sulfonylureas or insulin, then that's the especially those who are taking 2 doses of sulfonylurea twice daily, then the suhoor dose need to be lowered according again to the patient's control, level of control. Always be cautious with those who are having well-controlled diabetes to give them the same doses at suhoor. You need to lower them anything between 25 to 50%. And the main indicator here, or the most important point, to measure the sugar during fasting. And then you can adjust the doses according to the levels. If somebody is running 300s, 400s at 3 or 4 p.m., then you tell him, well, you need to increase your suhoor doses. If he's on 60 glycoside bar, go to 90, slowly, and adjust the doses, measure the sugar. Again, this highlights the importance of education. We need to teach them how to take care of their sugar. Most of them, unless they have the great service of telemedicine that Dr. Sofiani talked about, to call their practitioner or get the advice if they are hesitant to increase the doses. Most of the youngsters, they are really intelligent, and if you teach them how to adjust the doses at suhoor and adjust the readings and the intake according to the measurement during fasting, they'll do it nicely with the help of their educators. For us in the clinic, we don't have the telemedicine service fully applied. It's just phone calls. So they have a phone call, they have WhatsApp number, and they can call the educators during any time during the fasting hours if they experience any difficulties, and get the advices on the adjustment of the sugar. I must say also that the correction doses according to the insulin sensitivity and insulin carb ratios and so on need to be educated to every patient with type 1 diabetes, and they know how to take the correction doses during fasting hours. Very important to prevent DKA in these patients. Although many studies have shown that there is no increased rate in our hospital, for example, National Guard, over the years we haven't observed many DKAs admissions during Ramadan. It's on the opposite hand, and not even hypoglycemia. Most of the admissions is with hyperglycemia during Ramadan. And this is what we observed over 3 years. Look at our records of admission record in ER, which is electronic. More hyperglycemia cases come to the ER during Ramadan fast.
Thank you. Dr. Sofiani, which best candidate of diabetes group they can be followed safely in Ramadan as virtual clinic in fasting Ramadan?
So you mean which online groups?
Yes.
Yeah, so I might be biased here, but I would start with our own group. So we have the Diabetes Technology Group, or Diet Tech. So every year we conduct educational sessions with patients, and this year actually it's for tomorrow at I think 8 p.m. So it's Diet Tech. You could find it on Twitter and register. There are in many hospitals there are WhatsApp groups for patients that are supervised by diabetes educators. I would strongly encourage patients to sign up in these groups, even if it's just for the month of Ramadan, because they really need the education to be more focused, as highlighted by Prophet Saleh during this time. So these are the two things or two platforms that I can think of, at least for Saudi.
Naji, I would like to add to what our dear colleague and friend Mohammed said. If you look on Twitter, there are a lot of educational groups that are available. At least in the kingdom, I'm talking about the kingdom, many of the type 1 diabetes groups, for example. And I see that many of them, they have educators, they have some physicians with them, and they can be of great help to some patients who need quick access to information and advice. So I remember last Ramadan, they were putting questions and they will get answers, beautiful answers from experts to guide them what to do. Somebody has a sugar of 300 during fasting, a type 1 diabetic. And immediately the answers were really beautiful and correct advices. They are not out of the scientific recommendations. And always these groups are really helpful if they have an expert on board. MashaAllah, Muhammad's experience is really great. And I congratulate him for such work that he did and he published during using telemedicine and advanced technology in the care of our patients with diabetes.
Thank you. Dr. Bachar, a question: patient with type 1 diabetes and with microalbuminuria, does fasting affect his kidney function?
Well, we detailed actually the type 1 diabetes and renal involvement, and we classified actually to GFR of less than 30, between 30 and 45, 45 to 60, and more than 60. And we gave different scores for that. Proteinuria is a part of having the CKD. However, I know now some groups are working on the kidney patients and specifying whether they are on dialysis, hemodialysis, or PD, or so on. I would say for the score now, this actually covers renal patients with or without, significant proteinuria.
Yes, Dr. Yousef, how frequently do you would like to measure blood sugar or monitor blood sugar in fasting Ramadan?
So I highlighted that slide that the IDF-DAR recommends 7 times of measurement. And then they say any time that the patient feel hypo symptoms or hyper symptoms to immediately check the sugar. So 2 hours after iftar, 2 hours if possible after suhoor. Those sometimes it's not practical because those who delay their suhoor till near Fajr prayer, which is the advice actually to delay it as much as you can, and then 2 hours after 2 hours suhoor, and then noon time, 3 to 4 p.m. and immediately before breakfast. So 7 times, generally speaking, distributed across the day, and to adjust the doses for the medications according to these readings. I always advise them 3 to 4 p.m. and immediately 1 hour before breakfast are very important times if they notice hypoglycemia, to lower their suhoor doses, especially with long-acting medications. Higher sugars, they need to go up with the doses. They not need to be scared from increasing the doses as suhoor if their control is not good during fasting hours, but cautiously to avoid hypoglycemia. So the IDF-DAR nicely put that figure or graph that tells the timing of the monitoring. So fasting state, 2 hours post meals, anytime they feel hypo or hyper.
If I may add here, it's really very important to do that because, again, we reported a big difference between SMBG and CGM. And there is what we call unrecognized hypoglycemia for these patients. Especially in pregnancy, we reported that relying on the glucose meter is actually, patients were reporting checking the sugar at the wrong time. So they check more frequently after iftar, but they don't check before iftar. So, we should really, emphasize the importance of checking blood glucose or considering CGM or flash or whatever.
Okay, thank you. Dr. Sofiani, what's the impact of educational session before Ramadan to affect their fasting status or outcome during Ramadan?
Yeah, so this is a great question. And I think Prof. Yousef has rightfully emphasized that point. So education before Ramadan is very crucial. Sometimes the simplest things that you think are known to anyone, you get surprised when you start talking about them with patients that it's actually the first time that these patients learned about it. So for example, checking glucose during the day, as Prof. Saleh said, we still have patients who think that this is not permitted during fasting. So just setting these basics, when to check glucose, how to check glucose, is it the CGM or is it the blood glucose meter? When do you break your fast? When you could just observe your blood sugar and continue fasting? So all these things ideally should start 6 to 8 weeks before Ramadan. But as you see, we all have busy clinics. Patients tend to show up few weeks before Ramadan, trying to get on board with Ramadan doses. So it's ideal to see these patients and educate them 6 to 8 weeks before Ramadan. But the least you could do is just educate them few days before Ramadan when they show up in your clinic, and utilize all the online platforms that we have nowadays.
Okay. Now, I would like to each speaker take just 1 minute for conclusion. What you'd like to advise for people who's diabetic to fast Ramadan? Dr. Bachar.
Well, again, I think it's really essential for us to have a unified way to check, to check the risk for all patients. It's really confusing to patients and not easy on physicians to make the decision by themselves. You need something to help you and to decrease liability, and also to give confidence to patients that, this tool or modified tool, whatever, is helping physicians to make the same decision. You need to quantify that. And we have a lot of work that is going on that is assuring that this risk calculator is probably validated, and we will modify on that. But it's really important that we all stand together to support patients and to have the same, classification for patients.
And it is available online, the risk calculator score.
I'm sorry?
It is available online.
Yeah, it is available online, yes. It
Okay.
could be downloaded from the Apple Store and also from DAR.
Okay, DAR guidelines. Okay, Dr. Yousef.
If I might say one word about the best way to tackle fasting Ramadan for patients with diabetes is education. That's where the money lies. Education, education, and education to healthcare professionals to how to deliver the right care using the DAR guidelines, and to patients on how to practice safe fasting. If we do that properly and in amber time before Ramadan and guide the patient through the holy month, then majority of our patients will have safe fasting and fast probably the whole month if they receive proper advice, proper education before the holy month. That's all.
Dr. Mohammed.
Yeah, so I'm not going to repeat what my colleagues just mentioned. I think all of these points are very important. And instead of repeating what they said, I just want to thank all the people who worked on the Ramadan guidelines or the DAR guidelines, because over the past 2 years, these guidelines helped me a lot since I'm relatively new to the region as a practicing endocrinologist. So I had no strong training on how to manage these patients, but these guidelines got me up to speed. So thank you for the two of our speakers. And thanks also for Prophet Saleh for commenting on our work and publications. And I just want to shout out to one of our trainees, Dr. Sahar Al-Harthi, who's an internal medicine resident, who has led most of these projects on fasting Ramadan. Thank you very much for having me, and hope you enjoy the rest of the night.
Okay, I would like to thank all the speaker attendees. Also, my thankful for GAED for this opportunity to have this webinar. I appreciate the time to complete the feedback after you finish this webinar. Feedback will be displayed on your screen when you log out, and you can complete it only once. Just to remind you, CME hours will be sent to you in the same email after 1 month, and it will be Dubai Health Authority accredited. And be a GAED member now, and please you can visit GAED.info. and Ramadan Kareem وكل عام وانتم بخير. تقبل الله منا منكم وشكرا للجميع. الله يعطيكم العافية.